I have to talk about maintenance, and you know I probably have some bias on this, but I think waiting quietly year after year, the evidence on maintenance are definitely increasing dramatically. And I think more and more people are convinced that we are definitely changing paradigm from few courses, wait through the next one to a continuous treatment. And if I can say, we are changing a paradigm for the all facial myeloma to what currently we are doing to CML and other hematologic cancer. The first issue on maintenance and the evidence are that if you can see here for different study, both from lenalidomide or bortezomib, you can clearly see that 80% of the efficacy in terms of remission duration is coming from maintenance, not so much in terms of induction. And if you want to have a general idea, the improvement is between 1 year in patient after conventional treatment and up to 2 years in patient after autologous transplant. So we were often discussing and increase the CR between one cycle or one treatment or the other. Here, we have evidence of PFS improvement that is ranging between 12 and 24 months consistently in all studies that have been run. Look, this was the last study. And again, the story is exactly the same one after the other. You give 18 months of treatment. This is the outcome. Then you stop treatment. This is the outcome. You keep going with the maintenance, and this is the diverging of the curve. And this has been shown with lenalidomide, has been shown with bortezomib, has been to some extent a constant. The other issue that I did found quite interesting from this study is not only the change in progression-free survival, but the change in time to next treatment, that at the end of the day means the length of asymptomatic disease. And if you look at the length of asymptomatic disease, because theoretically, the rechallenge occurs when the disease becomes again symptomatic, not only when you have an increasing component, in M component, the number here are going from 26 to 39. So you are adding, beside the progression-free survival, another year or asymptomatic disease. So if you put everything one after the other, you start with 1 year of progression-free, maybe 2 in the younger, another year of asymptomatic disease. So here there is, I would say, a change in treatment paradigm, at least in this disease. What about overall survival? I would like to show this meta-analysis that has been performed by Hans Ludwig. And if you look at what is available, at least until December, you can see here that when you look at thalidomide, the numbers are 35% reduced risk of progression, 16% reduced of death. But when you put everything together, still you start seeing an overall survival benefit for thalidomide maintenance. When you look at the lenalidomide and you put together in a meta-analysis all available study, you find a 55 reduced risk of progression and 38% reduced risk of death, and the difference is significant. So in terms of meta-analysis, you might find some studies that have some contradiction, but in terms of meta-analysis, there is also an overall survival benefit. Then if you look at bortezomib, the story is basically the same. 29% reduced risk of progression, 27% reduced risk of death. So to some extent, what else do we need? And I think here there is a contradiction because the evidence are very strong. The issue is this cost effective? the cost of a continuous treatment, it's worth the advantage we are getting. This is another issue, but the issue is that everybody is confusing these two problems and are starting to see, I want to see survival and then I want to see something else. Beside, the real issue is cost efficacy. And from that point of view, I'm much more neutral than I am now presenting this data. Resistant relapse. Here is another issue that I think will come. And if you look, the problem is exactly the opposite. People is concerned about resistant relapse. I'm giving continuous treatment, then the relapse will be more aggressive. Of course, yes, I'm not saying no. But the problem is another one. If we think that plasma cells is regenerated every month, the risk of mutation and clonal evolution every month while you are regenerating the bone marrow without treatment is much higher than if you give a treatment, because the continuous treatment basically is keeping the tumor under control, avoiding a clonal evolution that clinically will come in a relapse. If you look from different studies, and when you look overall survival from relapse, the usual major progression-free survival, you don't see such a bad curve. The same in other studies, major improvement, but overall survival from relapse is not so bad. Now, this is a curve I will present also later on to tell you when you put together conventional plus maintenance, transplant plus maintenance. Please look here the adding value of every single approach. So no question that maintenance is improving, both conventional and autologous transplantation. What about the elderly patient? I think this is even another probably more important issue, because as Jagannath absolutely correctly was saying, we are now facing, it's not very clear today, there's not two patients for myeloma. There is the young patient transplant, there is the fit elderly, and there is the frail. And look here the difference. If you have a fit patient, you have 100 in terms of non-hematologic toxicity. The frail will develop 160. These are patients with inclusion and exclusion criteria. If you, as Sundar correctly saying, go to the bed, this 160 become probably 230. If you look at discontinuation in trials, you see 100, but then goes 180. So you can see that clearly EMA made a major statement. We do clinical trial where the frail population represents 15% of the patient population. In the real world, we give that drug, that dose at 60% of the elderly without any testing. And this will become a more and more problem. I'm not going this. Frailty today, to the best of my knowledge, is a prognostic factor that is much more potent both of chromosomal abnormalities and age. But this is the point that I wanted to make. The point is that especially in the frailty, we are going to the two drugs, but at that point you need maintenance. Because if you under-treat with the two drug versus the three drug, then you need continuous treatment. And the moment you start to compare two drug versus three drug with continuous treatment, we see it from O20, but other studies, no question that the two drug has an advantage. To close, I would like to make a point because they didn't allow me to enter in the session attached for the maintenance. They keep me outside. And beside this, I would like to make a point. Finally, I hope this will be clear for the future. Because this is a study, it is not a study, we are collecting data. It's not, we are collecting data from different studies. But the point I want to make is that if you start with 1,200 study here, then you do overall survival. Then, if you do PFS2, that will certainly become a major marker in the future, because PFS2 is from diagnosis not to first relapse, to second relapse. And therefore, you are balancing the advantage of the first remission and eventually the chemo-resistant relapse that you have from the second remission. But this is in intention to treat a serious analysis, because you start from diagnosis and you end up at the second relapse. What people do with second PFS, they start with 1,200 patients here, they have the first relapse, then they evaluate 600 patients and they say that there is a difference. They forget all the patients that are still in remission in the first progression-free survival. This is a major biased analysis, because basically you are evaluating 50% of the population. You are mainly evaluating the high-risk patient because, of course, are the ones that are relapsing earlier, and you forget it that someone, thanks God, is still in first remission. I'm not going in all the details, but if all the study, PFS2 is in favor of maintenance. Even the Michel et al. Study showed that PFS2 is improved during maintenance. Second PFS, no, but that's, to my opinion, the criticism, the major criticism on the use of second PFS. Last issue. When you do, this was a 1,200 patients, so last cohort of patients. Good prognosis patients do better than high-risk patients with maintenance. So the other message is maintenance is probably more effective in the good prognosis than in the high-risk patient. Conclusion, residual disease required maintenance. I think there is evidence of progression-free and overall survival benefit. I would say something that is important that is underestimated from a clinical point of view. In our clinic, we do deliver continuous treatment if all toxicity are within grade 1. Because if we are giving continuous treatment with a continuous grade 3 toxicity, this is not accepted, because maintenance must be an excellent quality of life. So with this, this should be always remembered. There is a reduced risk of resistant relapse. As I was saying before, there is a cost effect efficacy evidence that is required, because according to different society, budgeting and things like that,